Good day to all. Today we'll be talking about the brain's anatomy, its blood supply, and the clinical aspect combining the two, that is stroke. So to start off, let us look at the brain's anatomy. In the lateral view, we can see the frontal lobe, the parietal lobe, the occipital lobe, and the temporal lobe. Broadly speaking, the frontal lobe takes care of the voluntary activities. The precentral gyrus is responsible for the voluntary activities of the body. Then you have the frontal eye field that is responsible for the voluntary eye movements. There's also the Broca's area that is responsible for the voluntary movements that are required for speech. And then there's also the prefrontal cortex that takes care of control of emotions and impulses. Then there's the parietal lobe. Now, if the frontal lobe was for motor activity, the parietal lobe is for sensory activity. The postcentral gyrus is the last station for the relay of all the sensations of the body. There is also centers in the parietal lobe that take care of calculation, reading and writing, and spatial orientation. In fact, we can decide which parietal lobe is dominant and which parietal lobe is non-dominant based on the following. So in the dominant, there will be centers for calculation, reading and writing. And in the non-dominant, there will be centers for spatial orientation. Right. Now coming to the occipital lobe. The occipital lobe is the lobe that concerns itself with vision. That's it. And temporal lobe concerns itself with the interpretation of voice and sounds. Right. The temporal lobe also has the Wernicke's area that is responsible for comprehension of language, and also the lower temporal lobe is responsible for object and face recognition. Yeah. Now coming to the coronal section. On the coronal section of the brain, we can again see the frontal lobe, the parietal lobe, the occipital lobe. The temporal lobe is seen here. And the new structures that we see more clearly are the thalamus, hypothalamus, and the brainstem. Right. The thalamus is the final relay point for all the sensations of the body. That is, all the sensations come first, relay in the thalamus, and then go to the postcentral gyrus. There's also the cerebellum, and the cerebellum is responsible for maintaining balance and also responsible for planning of complicated activities or skilled movements. Right. Then comes the brainstem. The brainstem is the continuation of the spinal cord. Now the spinal cord becomes the brainstem at the foramen magnum. Right. At the foramen magnum, the spinal cord becomes the medulla oblongata, which further becomes the pons as you go up, and further becomes the midbrain. Right. Now coming to the inferior aspect. The inferior aspect more clearly shows the medulla, the pons, and the midbrain, and the cerebellum laterally. It also shows the olfactory nerve and the optic nerve. Right. And the rest will be the frontal lobe, the temporal lobe, and the occipital lobes. So this is the overview or the superficial anatomy of the brain. Now coming to the second aspect, that is area supplied by which arteries. Now when it comes to the blood supply of the brain, there are multiple arteries, and we shall go into its details in due time. But for now, when we are looking at the superficial anatomy over here, we should first concentrate on the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery. Right. So the now when you look at the lateral aspect, a majority of the area is supplied by the middle cerebral artery. The posterior cerebral artery supplies the occipital lobe, and the anterior cerebral artery supplies a small portion of the frontal lobe here. Right. So the lateral aspect majorly is supplied by the middle cerebral artery. Now when you look at the sagittal section, this is basically the medial aspect of the brain that we are seeing. So in the medial side, the anterior cerebral artery takes up the bulk of the blood supply. And the posterior cerebral artery, as previously, is supplying the occipital lobe. Now when you come to the inferior aspect, we can see the anterior cerebral artery supplying the medial aspects of the brain, the middle cerebral artery supplying the lateral aspects of the brain, and the posterior cerebral artery supplying the occipital lobe. Now let us discuss all the arteries that supply the brain. Right. So the brain's blood supply is divided into two parts. One is the anterior circulation and the posterior circulation. The anterior circulation starts off from the internal carotid, and the posterior circulation starts off from the vertebral arteries that branch out from the subclavian arteries. Right. Starting off with the posterior circulation first. Now, there are two vertebral arteries which are branches of the subclavian artery, and these vertebral arteries join to form the basilar artery. The basilar artery's terminal branch is the posterior cerebellar artery that we have discussed previously. Now, this is the main backbone of the posterior circulation. Now, in the anterior circulation, the internal carotid gives terminal branches, being the middle cerebral artery, the anterior cerebral artery. There are also some minor branches such as the ophthalmic artery and the lenticulostriate branch, etc. But that is not significant for now. So, these two are the anterior branches, and then there's also the posterior communicating artery. This posterior communicating artery helps the communication between the anterior circulation of the brain and the posterior circulation of the brain. Then there is also the anterior communicating artery that is given off by the anterior cerebral artery that can help the communication between both the anterior cerebral arteries. This structure that is formed over here by these arteries is called the circle of Willis. Now, this circle of Willis helps in blood flow through collaterals to supply the brain in case there is a decrease in circumference of any one of these arteries. Now, come in detail, we have to go about further branches. The vertebral artery gives the two branches that join from the anterior spinal artery, which supplies the medial medulla. The posterior inferior cerebral artery supplies the lateral medulla. The basilar artery per se supplies the medial aspect of the pons. The anterior inferior cerebral artery supplies the lateral aspect of the pons. And the superior cerebellar artery supplies a greater portion of the midbrain with smaller contributions from the posterior cerebral artery. Then the anterior cerebral artery, the posterior cerebral artery, and the middle cerebral artery supplies parts of the brain as discussed previously. Right. Now, this image superimposes the blood supply over the inferior aspect of the brain's diagram to help us understand better. This anterior cerebral artery supplies the medial part of the anterior spinal artery supplies the medial part of the medulla. The posterior inferior cerebral artery cerebellar artery supplies the lateral aspect of the medulla. Then there is the anterior inferior cerebral artery that supplies the lateral aspect of the pons, with the basilar artery supplying the more medial aspects. Then there is superior cerebellar artery that is supplying the midbrain. And here is the posterior cerebral artery, the middle cerebral artery, the anterior cerebral artery, anterior communicating artery, posterior communicating artery. And this is the circle of Willis. Over here we have the blood supply of the brainstem per se, and also the anterior component. And we also have cross sections of the brainstem at multiple levels. These three being the medulla, these two being the pons, and this being the midbrain. So what I would like to impress upon you by means of this image is the nuclei that are present at various levels and the nuclei that are present medially and present laterally, so that when it comes to localization of stroke, when we discuss it further, we can decipher which artery might be the one that is blocked that caused the particular disease based on the symptoms. So if you look at this, there are two rules. Number one is the rule of 4. Right. So this mainly says that each part of the brainstem has 4 nuclei, although it's not strictly applicable, but you can say that the medulla has 9, 10, 11, 12. You can say the pons has 5, 6, 7, 8. And you can say the midbrain has 1, 2, 3, 4. But in actuality, 1 and 2 are present in the cerebrum, whereas the nuclei of 3 and 4 are present in the midbrain. Right. Another thing is the rule of 12. That is, any number that can multiply, that has 12 in its multiples, will be present in the center. That is, cranial nerves 3, 4, 6 and 12 will be in the center, whereas all the other cranial nerves, them being 5, 7, 8, 9, 10, 11, will be laterally. So as here 3, 4, 6, 12 in the center, and 5, 7, 8, 9, 10, 11 are present laterally. Also, you can take a screenshot of this picture so that you can see clearly and identify the nuclei at various levels for a greater understanding although we will be seeing relevant pictures when we discuss stroke localization. Now coming to the clinical application. That is stroke. So what exactly is stroke? Stroke is basically what a myocardial infarction is to the heart, stroke is to the brain. And how could it happen? So basically a stroke is a decrease in blood supply of the brain to the brain, but there are many ways in which it could happen. The more common one being the ischemic kind. Ischemic kind. So the ischemia can be due to an atherosclerosis, which then critically blocks the blood flow in the blood vessel, or it could be an emboli from a different vessel that comes and blocks the brain's blood vessels, thereby leading to a decreased blood flow. Or it could also be hypertrophy of the vessel wall, thereby decreasing the diameter of the lumen of the blood vessel and thereby decreasing blood. This happens mostly in hypertension and in the smaller arteries, right? And then there is also another cause, which could be hemorrhage or rupture. That is, if the blood vessel supplying the brain ruptures and the blood leaks out, there will be less amount of blood going to the brain, right? But for the purposes of our further discussion, I would more concentrate on the ischemic kind of stroke, right? So in more complicated or in more professional terms, stroke is a focal or rarely global neurological deficit which occurs due to the decrease in blood flow to the brain. Now, when we talk about stroke, we should also talk about what is TIA or transient ischemic attack. Right. So, transient ischemic attack is basically like a stroke, but it is more of a temporary in nature. Normally, we move on telling ourselves such a simple thing, but in practice, we can't differentiate properly based on this description. Simply because unless the patient is talking about an episode that happened to him in the past, you cannot say whether it's a stroke or a TIA. Normal definitions used to say that if the neurological deficit lasts for greater than 24 hours, then call it a stroke, otherwise call it TIA. But this approach is flawed. Simply because if a person comes to you with symptoms resembling stroke, you simply don't have that much time, right? You can't wait for 24 hours and then send him away saying, oh, you have a TIA, please come back later, right? For this, a new sort of method has been developed, or a new definition has been developed based on tissue death. Now, this tissue death is seen on a diffusion weighted imaging of an MRI. So an MRI is done, and then on the MRI, if there is dead tissue, dead brain tissue, then it is called stroke. If there is no dead brain tissue, then it is called a TIA, right? The next thing that we need to understand when we talk about stroke is that it is popularly said that brain is a tissue that simply cannot survive anoxia or lack of glucose. But when we talk about stroke, we say a golden period of 4 hours or golden period of 6 hours and all such stuff. So how can the brain survive in the lack of blood? Right. So to answer this, we need to get into a little bit of math, right? So the cerebral blood flow normally is 100 ml per gram per minute to the brain tissue. But even if the blood flow falls to 20 ml per gram per minute, the blood will survive, but the patient will become unconscious. Any further decrease in the cerebral blood flow causes a time-dependent cell death. For example, at 5 ml per gram per minute, the brain tissue survives for around 30 minutes, whereas at 15 ml per gram per minute, the brain can survive for 3 hours, right? So, and also the collateral circulation of the brain is in such a way that it can supply up to 5 to 15 ml per gram per minute in the central zone and 15 to 25 ml per gram per minute in the penumbral zone. And now this is what gives us the time that we can take to treat the patient, right? So this is what to keep in mind, that the blood vessels are never completely closed. There is always some sort of space, right? The complete obstruction of blood is a very rare entity, and yes, if that happens, the brain tissue will definitely die and you cannot treat the patient. So this is the logic behind the blood surviving in decreased blood flow. Now coming to what is the pathophysiology of the cell death in stroke. So in stroke, what happens is there is a decreased blood flow. So this decreased blood flow will have decreased oxygen. So there will be anaerobic respiration in the cell, which will increase acid generation like lactate. And also there is reactive oxygen species generated. And then and these two in combination cause cell death. There also another branch of pathology where there is decreased glucose, so there is decreased ATP production, and also anaerobic respiration provides less ATP, so this is another cause. So these two together will cause decrease in sodium potassium channels. This will cause an increased depolarization of the cell, and the cell over here is a neuron, and that will cause increased glutamate release and reduced reuptake, and this will cause excitotoxicity and further cell death. Now coming to how stroke is classified. Stroke is classified using the trial of organs in acute stroke classification, or the TOAST classification. Right. Why this sort of classification is used is because more than 70% of all strokes can be classified under these headings. That is large artery atherosclerosis, a cardioembolism, a small artery occlusion, a stroke of other known etiology, and a stroke of unknown etiology. Now coming to clinical approach of stroke. There are things to keep in mind, that is, rule out stroke mimics. Maybe you could think of things like Wernicke's encephalopathy, or you can think of hypoglycemia, etc. Now these do mimic strokes and have to be ruled out before going further in management. Right. The next thing to keep in mind are accompanying symptoms. Now these accompanying symptoms are very important, especially if we wish to localize the disease even before we go for imaging. For example, let us say the person goes off balance. You could assume there could be a cerebellar stroke, sorry. Or let us say the person is having the tongue deviate to one side. You could think the hypoglossal nerve is damaged and therefore the medial medulla is damaged. Right. So this we will discuss further in great detail when we come to the localization aspect. Then coming to the temporal course of the disease. Let us say the symptoms were severe in the start. Right. So if the symptoms are severe in the start and are reducing now, you can think in terms of a hemorrhagic stroke. And if you take the reverse, that is, symptoms were less in the beginning and are slowly increasing as time progresses, you can think more or less in terms of an ischemic stroke. Another thing you could take into consideration are the risk factors. For example, let us say the patient only has hypertension, right? So if there's only hypertension, you can think of that hypertension is causing hypertrophy in the blood vessels, and thereby you can think that the smaller vessels are affected, right? And that is leading to the stroke. Or if you take a risk factor such as diabetes, hypertension, and previous TIAs, etc., we can think that the person is already suffering from some hypercoagulable state, and thereby you can think of atherosclerotic or thrombotic causes of ischemic stroke. And lastly, let us say the person has arrhythmias. Now, when the person has arrhythmias, especially if you take atrial arrhythmias, right, you can more often than not imagine emboli forming in the heart and those being transferred to the brain and thereby causing stroke. Right. So you can go for the cardioembolic sort of pathophysiology. In this video, we have seen brain anatomy, blood supply, and stroke. And in stroke, we have seen its definition, how it is different from TIA, and we have also addressed concepts regarding stroke such as its pathophysiology, classification, and clinical approach. In the next video, we shall address localization and management of stroke. Yeah, hope to see you in the next video. Thank you.